All right, everybody. Good afternoon, and welcome to today's webinar, Stronger Together Against HIV, Co-Infections and HIV Care, in partnership with the National Coalition of STD Directors. This webinar will enhance participants' understanding of co-infections and HIV care through clinical and disease intervention perspectives. We will highlight best practices and strategies to improve health outcomes for underrepresented communities. My name is Anneli Roque, and I am an infectious disease doctor at Emory University, along with my colleague who is joining me today. I'm the site chief for infectious diseases for Emory University Hospital Midtown in Atlanta, Georgia, and I'm really pleased to be with you today. A couple housekeeping things. So this webinar is being recorded and will be made available on the NHMA and NCSD YouTube channels and websites. Please submit questions through the Q&A box at any time, and we'll have time for a live Q&A at the end of our conversation. For those of you that may not know or may be new to NHMA, we are a nonprofit organization that represents over 50,000 licensed Hispanic physicians in the United States. Our mission is to empower Hispanic and other underrepresented healthcare professionals to improve the health of Hispanic and underserved communities. We advance this mission through leadership development, health policy advocacy, education, and strategic partnerships with federal agencies, academic institutions, and community-based organizations across the country. Our other partner today, NCSD, is a national public health membership organization representing health department STI directors, their support staff, and community-based partners across all 50 states and U.S. territories. NCSD seeks to build capacity, knowledge, infrastructure, and resources for our members by providing technical assistance and training, developing and sharing informational resources, facilitating peer learning and support. And our capacity building priorities are identified through member needs, assessments, and input by board committees and the board of directors. So today I'm really pleased to be joined by my colleague, Dr. Carlos Saldana, who is an assistant professor of medicine in the Division of Infectious Diseases, where I am also faculty at Emory University here in Atlanta, Georgia. So to begin, I'm going to go ahead and just jump right in. So Carlos, tell us a little bit about what you do, who you are, what your background is, and the work that you're doing related to HIV care.
Thank you so much, Anneli. It's a pleasure being here. I would like to thank the National Hispanic Medical Association and the National Coalition of STD Directors for the opportunity to be here. I am an HIV provider, clinician at the Ponce de Leon Center here in Atlanta, Georgia. I've been very lucky to have the vast majority of my patients being from Hispanic, Latino backgrounds, many of them being immigrants. So I would love to talk a little bit more about the work that we are doing with CDC, the Georgia Department of Public Health, and local and in the HIV epidemic priority jurisdiction in the state to prioritize the health of Hispanic and Latino communities. I'm the site PI for the Georgia site for the AIDS Education and Training Center here in Georgia. I was also recently elected for the board of directors of the HIV Medical Association, where my work would be continuing to prioritize the health of our Hispanic and Latino communities. So I'm very happy to be here and talk a little bit more. So it's a conversation about how can we improve the health of our communities. Thank you again.
Thank you, Carlos. That really helps us provide a good framework for the conversation today. And we're going to jump right in and talk about first co-infections from the clinician perspective. And you and I are both clinicians. And talk about how that can affect people living with HIV and what healthcare providers and care teams can do to identify and address them effectively. So I think the first thing is, can you talk about what are co-infections and what are the ones that primarily are affecting people with HIV, and what should we as clinicians and care teams be mindful of?
Yeah, I think that is an excellent question. I would like to start by saying that today, August 2026, HIV is a manageable condition in which people can take a single pill every day. And more and more people are also accessing long-acting injectable medications that substitute oral options, and they can live long, healthy lives. And as HIV clinicians, sometimes we HIV takes the back seat because it's so manageable now that oftentimes we forget about other infections that can occur in people with HIV and at risk of HIV. We forget that other sexually transmitted infections can occur: syphilis, chlamydia, gonorrhea, monkeypox, herpes. Hepatitis B and C can also occur, and tuberculosis. So as HIV takes the backseat because it's so easily manageable and people live healthy lives, we have to think of this other infections and treat them accordingly.
That's so true. I find that in my visits, a lot of times the last thing that I talk about is HIV. And I'm talking about number one, two, and three, which are other things and tend to be cardiovascular conditions, and a lot of times, like you're mentioning, hepatitis C, which I've recently treated a couple of people for. And it is still something that is very prevalent. So when we think about prevention and early intervention, screening is an important starting point. So what are some of the current best practices for screening people living with HIV that are also have co-infections as the ones that you're talking about? And how can healthcare providers make sure screening is incorporated into routine HIV care?
It has taken me a long while and to find the way that works best for me. And a lot of this is normalizing and incorporating it into my routine practice. It's hard sometimes to have sexual health conversations with patients. So luckily, there are people out there that develop these frameworks that make it easier for us to start having these conversations and then having honest conversations with our patients. We've heard about CDC years ago put out a framework of the five P's of pregnancy, sites, prevention, and partners, so that can sort of help have those conversations in a shape in a form of a checklist. But more recently, I've come across some other frameworks that going from a checklist to more of an action oriented approach. So I would like to offer the goals framework that had been developed in New York City. So goals also starts. It gives you a framework so it's easier to remember. With the G being give a preamble, normalize telling people that, hey, I talk about sexual health with all of my patients, so we're going to be switching our practice or a conversation into this. The O is for offer opt-out HIV and STI. We tell patients that everybody should be screened at least once in their lifetime for HIV. And depending on certain exposures, we may offer screening for sexually transmitted infections and HIV more frequently. A is for ask open-ended questions. So it's important to ask questions like what is a healthy or your ideal sexual health would look like. So asking open questions like that. Then taking a step back, the L is for listen, and the S is for having suggest a course of action. So let's move from just moving a checklist, but hey, now that we had this conversation, let's have a course of action. Let's talk about which site to screen. I feel like sometimes some of the missed opportunities is that we don't know how to take a sexual history of that. We focus heavily on just urine testing, but any site that people are having sex should be screened for gonorrhea, chlamydia in the throat, gonorrhea, chlamydia in the perianal area is also very common. So having those honest conversations and telling people that it's normal and that we do this all the time is quite important.
I think you sort of answered my next question, which was going to be what are some missed opportunities or gaps in screening. As you were talking about, these are really hard conversations that I think as the ID doctors we're more accustomed to having just because we have them every day. But even then, as you're saying, common missed gaps are just doing urine as opposed to rectal and oral swabs. And then I think for me to interject a little bit my own experience, I think the other missed opportunity is just making assumptions and making assumptions of the person that is in front of you. Because I think over time you recognize that the face of HIV in the United States is multifaceted, and it could be anyone. This disease doesn't discriminate, and we shouldn't make those assumptions about patients or about any other of the co-infections that come along with it. So once you identify that co-infection, what are some of the key considerations when it comes to diagnosis and treatment, and how do you balance that with treating their HIV, particularly when there could be issues with drug interactions, someone doesn't like to take the first pill, much less the second pill, or doesn't want to come in for those shots, or just general challenges with adherence.
I think that's a good question. What I do with my patients that are recently diagnosed, oftentimes, as we know, especially for Hispanic and Latinos, we postpone coming to the doctor for a very long period of time. We think that things are just going to get better. And unfortunately, with HIV, we don't access treatment at time. And we start seeing those infections that occur when our immune system is very weak, conditions that healthy immune system or bugs, funguses, viruses that healthy immune system can deal with. And people with advanced HIV, that becomes a problem. And when we cannot manage at home, then people that recently immigrate that don't understand the healthcare system, they start coming into our hospitals with very advanced conditions, and that is really heartbreaking. So those are the times that, at least in our Hispanic groups, unfortunately, that is the sort of the most common type of people getting diagnosed when things have taken a longer course. And compared to other racial and ethnic groups and age groups, Hispanic and Latino groups are being diagnosed at later stages of HIV. So oftentimes we see people coming in with co-infections like tuberculosis. So it is important to know that certain drugs that treat tuberculosis interact with the primary line or first line therapies that we have for HIV. Drugs like rifamycins that are often used to treat tuberculosis interacts with certain ARTs. So it's important to look into that and work with our pharmacist to identify potential options. People often come with hepatitis B, and it's important to offer people living with HIV options that treat both HIV and hepatitis B, which are currently available. We do not want to forget that HIV is also hepatitis B is also manageable. And some other things is that as we tell people that that this condition is treatable, that we will be monitoring their kidney, their liver function, and that they should be able to live healthier lives. Sometimes if they feel that sometimes if it's also important to remind them that as our immune system starts to wake up, it starts fighting some infections. So we should expect to not feel absolutely fantastic right away. Our immune system has been taking a break, so we'll start fighting anything that it finds in the body. So just making that clear so people adhere and push through those initial phases is quite important.
That's so true. I feel like for us Latinos, a lot of times it's like your foot has to be like hanging off before you end up going to the emergency room, or we just leave things until like the last one because we just think they're going to get better. In those situations where you are treating TB, you're treating uh, PJP or pneumocystis, or you're treating something else, are there, how does that coordination with other subspecialists or the other members of the care team work? And how do you balance those priorities?
It is really important. I have to acknowledge my privilege that I practice at a center that has access to pharmacists, mental health, oral health. We have case manager, patient navigators, people that can help me coordinate all of that care because I'm very lucky that I don't have to do that on my own, and that sometimes in rural areas, which is something that through our um, Center for AIDS Education and Training, we're looking to prioritize and engage because it can take a toll on an individual and a provider when all of these things merge into one. So being able to offer that medical home that has pharmacists, mental health, substance use provider, social worker, case manager is so very important. And because HIV does not occur just because somebody decided to just have sex with a male decided to have sex with another male. There are some other things like being unable to access highly effective tools to prevent it. So those are the other things of not being able to have a place to leave, or not being able to have here, for example, in the state of Georgia, people that don't have that are undocumented can even access uh, um, driver's license and are scared of coming to the clinic. So it takes a lot of coordination to really provide the care that our communities deserve. So trying to advocate and sustain and apply for grants that provide a medical home is so very important, very similar to the work that you guys do at Emory. Is so very important. I'm sure that you also have similar examples of people that sometimes just fall off the cracks because are unable to get an Uber, or because that they get turned away at the pharmacy because they don't speak language and don't understand the requirements of being enrolled into Ryan White or the or the AIDS drug assistance program. So it is so important to provide those multidisciplinary components to be able to enroll in so the community has.
Absolutely. I think just to echo what you said, that this is what we do as a team sport. And the you sort of again answered my next question, which was about integrated care, because we both work in systems that we're grateful and very fortunate to have integrated care where we have PCPs nearby. If we can't service PCPs, we have pharmacists, we have case managers, we have behavioral health professionals and other members of the team because we cannot do this all alone. Um, but I'll provide one brief anecdote which kind of highlights what you're talking about. Because for our population, for our Spanish-speaking monolingual population, the role of or lack of translators is also a huge thing, right? And that is such a huge care barrier when you think about that, along with transportation. I have a patient who is one of the few patients that I've given my direct email to because she has not been able to figure out my chart, and she emails me in Spanish, and she there's very few signs here in my hospital in Spanish, unfortunately. And things like calling the pharmacy where nobody speaks Spanish to get her Biktarvy sent to her new address. That's a huge care barrier that she can't do, right? And so she emails me directly so that I can help facilitate that. And I work with the social worker to kind of make sure that that is happening. But those little things become really huge things for people that have challenges overcoming that burden, and then they can't get their medicines and they fall out of care, and that's when things really go awry, as you're kind of alluding to with the immune system going down. So, looking ahead, what are some of the most promising opportunities or emerging practices that could help us improve outcomes for folks that are living with HIV and something else, whether that's something else would be STIs, hepatitis, TB, etc.
I'm really excited. Some of the work that we do here at Emory is leveraging emerging technologies like artificial intelligence and telehealth and mobile health. So I think that what is exciting in the field is that going from an approach that may be reactive or just trying to, when people come to the hospital with late stage disease, what can we do? We collect a lot of data through electronic medical records, through reportable disease, STIs and HIV, go directly from the lab to the health department, so health departments can keep the pulse of how HIV is moving in our communities. So how can we leverage that big data to offer outreach to people before they have to come in with advanced HIV? So I think that is quite exciting. How can we leverage AI also to provide conversational assistance and support and translation to people? Because oftentimes, and just to the example that we have to remember the type of people that often feel pressure to emigrate, and the countries in Latin America, Central America, and the Caribbean that are lucky to have healthcare that is universal. So people is not used to having to, well, what is Ryan White? What is a stroke assistance program? What do you mean that I cannot just go to a hospital and I get taken care of? What is a copay and benefit eligibility reassessment and all of those things that even for somebody that speaks English like myself, it's taking me some time to understand all of those barriers and why am I not able to refill my medicine? Why do I have to have this visit? What is a CD4 count? What is an HIV viral load? All of those things become so challenging for somebody that we have to remember oftentimes have completed or not completed middle school and being forced to come here to work jobs in kitchens and construction and environmental services. So it's quite important to have that. And I've learned the hard way sometimes when I'm interviewing for my research with people in which, as we talked earlier, we have access to long-acting injectables. And I'm doing qualitative research to ask them, what do you think about long-acting injectables? And oftentimes people haven't even heard of them. Or what do you think about doxepin? And I haven't even heard of doxepin. So sometimes I'm asking our communities, our Hispanic communities, about long-acting injectables, but they cannot even access Truvada, which is a pill that it's generic now to prevent HIV. So really taking a step back and focus about how can I make this tools available. So we have a project here in Atlanta that is looking to expand telemedicine for Hispanic and Latino communities, bilingual telemedicine for HIV care and prevention, and also offering mobile services for phlebotomy and testing. So people can have a bilingual provider closer to them, and they do not have to come to the clinic to get those lab work, because that is also a barrier. But how can we, as a healthcare system, go in an unmarked vehicle, because the stigma is also very huge. If you have a vehicle that has a Grady or an HIV sign, people may sometimes be reluctant. So how can we have mobile phlebotomists go to and meet people where they are? So that is quite exciting in terms of HIV care, but also doxypep. We have now doxypep is this prevention tool that includes doxycycline 200 milligrams within 72 hours of sex to greatly reduce primarily chlamydia and so to a lesser extent gonorrhea and syphilis. But how can we make those tools even just generating awareness that they exist so people can start having important conversations with their clients? So there are very exciting tools, I think, that we can end HIV in our lifetime. But if we don't reach our communities, which I'm not sure I mentioned this, but at least in the state of Georgia, Hispanic and Latinos are the only group that is seeing increases in new HIV diagnosis to over 77% from 2019 to 2024. And we're seeing decreases in other communities. We're seeing decreases in white communities. We're seeing stable or decreasing rates in Black African American communities. But why? why are we seeing these increases in our communities? And it's because this prevention tools, this exciting innovations, it's such a great time to be in the HIV STI field. But unfortunately, our communities don't even know about it or are scared of going to the doctor. Just today, I was in my clinic in Palms, and I had suggested a long-acting injectable option for the care for HIV care, one of my patients. And he told me today, like, hey, yeah, I know we talked about it, but in the current situation, I don't want to be coming to the clinic every other month. I don't feel like leaving my house. Fear has become a determinant of health, fear of leaving our house. And the week prior, when I was with somebody in clinic, he has his sister on speakerphone when we are in the system in the visit. His sister was frightened because when she dropped him off, she saw eyes chasing somebody um, um, at the side of the clinic. So hearing her frightened in her voice, like, "Hey, I just saw somebody being chased by eyes." It's just it's just such a terrible time that we live in socio-politically. But in terms of biomedical innovations and HIV care prevention, this is an exciting, it's an exciting time. And hopefully in the midterm elections, we're going to see some. So I'm optimistic, and I encourage everybody here to vote so we can see some changes that because the impact in the health of our communities is so ginormous because they are not able to access what other groups are able to.
That's such a good point, Carlos. And I encounter that on a weekly basis as well because I think you can innovate till the end of time, but if that's not getting to the people that need it, there's no real point. And I don't think we can have this conversation without talking about the current political situation, the effects that the ICE raids and the targeting of Latino communities has had on access to healthcare and the fear that comes with accessing healthcare. And that is something that we are seeing across the board in our population of people living with HIV because they don't want to leave the house. They don't want to leave the house. And so a long-acting injectable, like you said, that where you have to come every 8 weeks for an injection in a clinic, that's going to put you at higher risk. So you're not going to do that. You're going to stay in your house where it is safest and not go outside and be chased into a health clinic or worse. And so I think that that really highlights that both of these things come together. The political aspect is very important because it affects the public health aspect, and then the public health aspect intermingles with the health of the community, which has a lot to do with the economic advancement of Latino communities and such. And so I want to shift perspectives a little bit, talking about disease intervention strategies for the next 5 to 10 minutes, roughly before we open up to questions. But for those who may not work directly in public health, can you explain the role that disease intervention strategies play in identifying, preventing, and managing co-infections among people living with HIV?
Yeah. So that's a good question. So I've been lucky to function as a clinician that also works closely with the health department. And for me to learn, when I started doing this work, I didn't even know that gonorrhea, chlamydia, syphilis, HIV get directly reported to the health department and how that works. So as a community member, it could be surprising and even feel often surveilled. So I've been doing this work for quite some time, and there was some understandable hesitation as to why is this being done, and those conversations have gotten harder when we see that this information like Medicaid, information like being information for Medicaid enrollees, or information from the Transport Security Administration, TSA, is being used for immigration purposes. So my approach has become a little more conservative of this conversation about because we cannot guarantee that this data, there are protections to this data, but we've seen so many things and so many outrageous things happen with public and federal data occur that it's just really hard to have those conversations. But in an ideal world, we this information gets reported to the health department, and that's how we keep the pulse on how syphilis is behaving in a certain location, how congenital syphilis, which is another infection that has been going through the roof, and it's a preventable infection, and it's because many women are not accessing prenatal care, and this is something that impacts um, um, baby health, maternal health. So it is so important that to keep the pulse on this infection so we can guide and design interventions from the public health standpoint. We've also done work with just to understand where and how HIV is transmitted rapidly through HIV molecular epidemiology. So it's so important because once we identify this, once an infection is identified, the health department has DIS, disease intervention specialist, that can provide outreach to that person, ask them about partners, and then reach out to these partners in an anonymous way to offer them access to testing, treatment, prevention, and any other services that they may be eligible. But if we don't do that with trust, if we're not unable to do that work effectively, and people don't trust the government. It's just so challenging. So offering resources for substance use disorder is so important. So the work that the health department does and why it is important to frame this not as we are looking at you, we're looking at your community and your network. So hopefully we can halt the transmission of HIV or there's other conditions, hepatitis, tuberculosis, so we can offer and make people aware of all the services that are available to them that otherwise they may not know about.
I think you're really highlighting that this requires a lot of collaboration between not only the care teams that we were talking about before, but also healthcare providers and public health agencies, public health directors, counties, as we do here in Fulton County. And in order for all of this to run effectively, everybody has to talk to each other, and there has to be a lot of trust, which I think is some of the things that we're sort of been missing the last year, or a lot more. And for everything to work effectively, and for partners to be alerted, for these rates to go down, we really have to be in sync. And so I just want to echo what you said, that the policies that are put in place by federal agencies and administrations really impact and have a trickle down effect, and go down to the communities that we work in, and the people that we take care of, and our people. So I think we could talk for a while, but in an effort to shift gears and let folks have an opportunity to ask questions, I think we're going to transition now to the audience question and answer portion of our webinar. But I think people could hear from you for a long time if we had enough time. So I'm going to transition now to the Q&A. So thank you for all your insights, Carlos. Continue to submit your questions through the Q&A box if you haven't already done so, and we'll prioritize audience questions and get to as many as we can within the time frame that we have. So I think right now we've got a couple of important questions that I definitely want you to have the opportunity to answer, Carlos. So the first question is, does this lack of information tend to be due to stigma within the Latino community? I think they were alluding to some of the information that you were talking about earlier, about lack of knowledge about LAIs, about doxypep, about these sort of new novel treatments.
That is such an important question, and we can talk about this for hours. And we're
Yeah.
putting together a symposium next month on the next year on February here on stigma and this current infections. But it is such an important question. When I came to Atlanta in 2020 to do my fellowship, I was under the impression that the health department it was obvious to me that there must be information in Spanish about STIs and HIV in a city like Atlanta. as the United States. I'm an Ecuadorian. I was born and raised in Ecuador. So to me, the United States thought that it's on top of everything and that that information must be out there. It turns out it isn't. And for somebody like Hispanic and Latino that has intersectional stigma, the stigma about being an immigrant. I already don't belong here. So why am I even going to bother asking or trying to go to a hospital because they don't care about me. I want to be under the radar. I also have the stigma about religious stigma that sexual health is no, we don't talk about it. That's it. I'm not going to talk about sex or anything related to that. The stigma about HIV. When we grew up and we saw that people in hospitals and beds macerating themselves very thin. I don't want to talk about that. That HIV, I don't want it. People forget that again in August of 2026, people live normal, healthy lives. Also, the stigma of being gay. The I don't want anybody, I don't want to have that conversation because then I may have to disclose that I'm gay to my doctor. So the stigma of family, the stigma of my family knowing about this, it's quite important. Then all that compounded with my work in the kitchen or my work in construction that goes from 5 a.m. to 7 p.m. I don't have time to go to a clinic. And then wanting to be under the radar. People don't want to talk about HIV because sometimes people think that if I get my blood test, it's going to go to some database and then I'm going to be deported. So it's all this compound of that plus what is happening right now sociopolitically, all that fear that really explains in a part about what we're seeing in our communities. And then if after all of that, for some reason, I get to call to the health department, pick up the phone and say, hey, I'm ready to talk about PrEP. That other person on the other side doesn't speak Spanish, then I'm done. I tried. So it's quite tragic what we are seeing and why it's so important to invest in the work that these organizations are doing to expand the pipeline of physicians and nurses and pharmacists and nurse techs and all across the front desk. So it is because taking that first step, if you for some reason took care of all those layers and picked up the phone or went to a clinic and then they look at you and they don't even have somebody to speak in Spanish, then you're like, I'm done. I'm gonna go back to be under the radar because the system is not designed for me.
That's so true, Carlos. It's like there's a certain point where you just, you get tired with all these other challenges and burdens that you have. You try it as much as you can, and then that's the end of that. I want to give you an opportunity to answer a couple more questions, which I think are really important in the time we have left. One is about HIV home testing. So, do you think HIV home testing could be an effective strategy for increasing HIV testing among Latino communities? And I know this is a very hot topic.
It is really important. And so some things to consider, any test is better than no test. Some lessons of this is that it sounds fantastic, but believe it or not, we some years ago through the Fulton County, we had a program in which people would request that test. And oftentimes, number one, it is important to collect all that data, but if you're going to ask people to request that test and then ask them about where do you live and how many partners and what sites, and if you make it, I love low barrier, order that test. But sometimes even when we send that test, people just don't return it oftentimes. So it sounds fantastic, but it also, how can we make it available, understandable, easy to see, like, because sometimes it depends. It's going to be a mouth swab. Sometimes you have to have it, put some drops of blood in the test. So making those instructions quite clear, having somebody on the other side to troubleshoot making it clear that this is not reported, this is not for any immigration services, making it sure that people know it's free, not linked to any immigration status. I think that it's quite important. And it's again, it's better than no test. But what about we're talking about the benefit of being able to go to a clinic in which this conversation is about what about hepatitis, what about tuberculosis, what about gonorrhea, chlamydia, syphilis, monkeypox, herpes. Um, it's quite important. So again, home test better than no test, but let's not forget about the other things that sometimes are more difficult to do at home.
Right. That's just the first step of a chain. So last but certainly not least, and perhaps most important in the current world that we live in and the times that we live in, another person listening is asking, what healthcare policies do your clinic have in place during this time of ICE enforcement to protect the health needs of your patients?
That is an excellent question. So Gray developed a document that was disseminated to all providers. And we've learned a lot because I've also conducted interviews with leaders across the nation about what are they doing to respond. So there are a couple of things to consider. Simple things as ice-free zone, having a sign that says ice-free zone can be very welcoming. Having protocols of what to do. Some organizations are rooming people when somebody is identified or somebody that could have an undocumented status, rooming them to the back of the clinic and being able to, they're not in a public space is quite important, but we have to also remember that can be stigmatizing. But if we want our goals to protect this person from not being deported, it's important. Being able to have available in your clinic the know your rights, and there are a lot of organizations that have put together flyers and information about know your rights and how to act if you are encountered by an ICE agent. It is important to disseminate that information. Several clinics have started to incorporate medical legal partnerships within consulting with lawyers of what to do and being able to provide legal assistance to people. Because if again, if it's so important for people out there, for our communities to have a regular status, why couldn't our clinic be able to offer that service and consultations with immigration lawyers? So people are leveraging some of those and having clear protocols about how to act if AIDS is being if ICE is being reported in the surrounding areas. What are some clinic best practices? And there are a variety of documents out there and protocols of that work best depending on where you live. So it's been quite inspiring to see that people are acting and offering some of these services and adapting to these very challenging times. So those are just some things that come to mind.
And I will say on our end here, we have personally stolen a lot of Grady's wonderful protocols, particularly because our organization has not been as proactive about sharing some of these things. And we have taken it upon ourselves as a clinic to make sure that our patients feel protected and feel safe. And so as such, we have adopted informally a lot of the policies that Grady has. And I encourage folks that are working in organizations that have not developed those policies to look towards others that have and see if they can share them and push your leaders to be able to give you that leeway to do so that you can adequately protect your patients. Thank you, Carlos. Thank you, Dr. Sardana, for joining us today in today's webinar on co-infections and HIV care. We touched a lot of topics related to co-infections and even more that are equally as important. So before we close, I want to highlight a few important resources and next steps for everybody. So I want to point you to the trusted tools and information from the CDC's Let's Stop HIV Together campaign, highlighted here. And then I want to share a little bit more information about NHMA, but we also encourage you to follow NHMA on Instagram, LinkedIn, Facebook, and Threads to stay updated on future events and initiatives. I want to highlight their weekly email, which I think is great and has a summary of a lot of policies and policy initiatives that are happening throughout the country that affect Latino communities. I have found that to be really important resource every week. So you can access downloadable resources and more at hispanichealth.info, our bilingual health education hub as well. And then if you are not already a member and we have not and we have convinced you today to become a member, we invite you to join the NHMA network, whether you're a provider, an advocate, a student, or a community leader. There's a place for you here, and I think there's a lot of power in community. Before we close, I want to highlight a valuable resource that NHMA offers, which is our job board. So simply scan the QR code on your screen or visit our website to explore opportunities and connect with others in our network. Thank you again for joining us today to have this important conversation. And remember, we are stronger together against HIV, and the fight continues. So everybody have a wonderful afternoon.